Welcome, hello. Welcome to the ISQA presentation to support this conference on COVID-19 and nursing homes. We're going to talk today about a pathway to achieving reliable and sustainable processes in nursing homes. My name is Gail Nielsen, and I'm coming to you from the heartland of the United States in the state of Iowa. I am a patient safety expert for ISQA and here to share with you a perspective from my experience with nursing homes over the past 8 years, including as a board member of an Iowa senior living community and as a board chair during the COVID-19 outbreak this past year. I will also share with you my learning from work with the Institute for Healthcare Improvement focused on nursing homes, including the National Nursing Home COVID-19 Action Network. For an introduction to nursing homes in the United States, there are a few different types of facilities. They include nursing homes, long-term care, skilled nursing facilities, short stay, and assisted living. Approximately 1.4 million Americans live in nursing homes. 2/3 of those rely on state or federal funding. Nursing homes in the U.S. is a place for people who don't need to be in a hospital, but can no longer be cared for at home. Some of our nursing homes are like hospitals with medical care and specialties at therapies. A continuing care retirement center or community includes all of the levels of care. These may require a buy-in for progression to the multiple levels of care and services provided. Many facilities offer special programs for people with Alzheimer's disease or other types of dementias. Depending on the acuity of care in a nursing home in the U.S., there are many roles of people who provide care and services in the clinical settings. Those include doctors, nurses, nurse practitioners, certified nursing assistants, personal care aides, and a required position is an infection control practitioner, and of course, many other roles. Skilled care is a higher level of care closer to a hospital, including residents on ventilators. Short stay facilities provide transition from hospital to home, and they include rehabilitation professionals such as orthopedics and physical therapy. The role of the patient safety manager is not yet foreseen in these structures. At Luther Park Community, which I will describe to you soon, patient safety is a part of the role of the quality improvement director who is not trained for patient safety specifically. I serve in that role for Luther Park and continue to mentor the board, the quality committee, the senior executives, and the quality improvement director. We thought you might like to see a bit of a comparison of the differences in senior living and COVID-19 impact between Italy, Iowa, and the United States. This chart might be helpful. As you know, overall in Italy, the population of persons age 65 and greater is actually larger than in some other countries. Iowa's population of 65 and older is greater than in the United States. Our oldest states in the US of Maine and Florida have an age of 65 and older population far greater than 20%. Italy has a higher percent of population in assisted living compared with Iowa, while the US has a much higher percent of population in nursing homes and assisted living. Italy's deaths overall from COVID are a bit higher at the time of this data, which was earlier this month. Deaths from COVID in the nursing home in the US are very high and only a little better in Iowa. The only data we could find on Italy's COVID deaths out of the total number of nursing home guests was 9.1%. Luther Park Community is located in the city where I live in Des Moines, Iowa. I'm about a 6-hour drive west and a little south from Chicago. It is a senior living community with all levels of care, from nursing home and skilled care to assisted living and independent living. We have 2 buildings of apartments for people who live independently and enjoy some of the food services in our facilities. In 2019, Luther Park adopted and adapted the IHI Guidance for Our Framework for Quality and Governing Quality. The guidance includes a framework, a self-assessment, and 3 support guidance. The example of a change that this framework enabled for our board was to make fiduciary responsibilities of quality and finance equal in time and focus. It was a big change welcomed by our board members. We made revisions to the IHI self-assessment, translating language from for long-term care and senior living because the original hospital language of the document was not helpful. The adaptation we developed is available to you for your further adaptations with the permission of IHI. At Luther Park, our quality infrastructure begins with a 12-member board. 3 of these members have a clinical background or experience. The remainder of members have business backgrounds. The board and staff meet together for critical discussions, including the training and the governance of quality. The board's quality committee has 4 board members and 3 administrative staff members, including the director of quality. The QAPI committee, and I'll explain that more later, it's the Quality Improvement Committee of the nursing home. Those members are all nursing home staff, and they're led by the Quality Improvement Director. The board's quality committee, with input from staff, establishes annual quality goals which the senior executives own and cascade across the organization. The required QAPI program addresses patient safety regarding things needed to be improved, such as fall-related injuries, infections, and pressure ulcers, but it does not call it patient safety. Training in patient safety, as we know it, is uncommon, and it has been brought into some facilities by senior executives who were trained in hospitals. The aim of this infrastructure is a system of high-quality, person-centered care. QAPI stands for Quality Assurance and Performance Improvement. It is a U.S. government mandate for all nursing homes receiving payments from Medicare and Medicaid Services, CMS, for the services provided. Though resisted at first, for many nursing homes now recognize the useful guidance for process and culture improvement. At Luther Park Community, we have expanded the focus from not just our nursing home, but to all levels of care, including independent living. Senior leadership provides the roles and supports needed, and they're needed for establishing performance measures, studying and learning from failures, developing actions and follow-through, and sustaining improvement. It's really all about a systems thinking and a just culture and a systems approach for every department at every level of service. The infrastructure also includes communication of problems and ideas for change and improvement. Government expectations for QAPI include reports on changes being tested, changes that worked and should be considered for spread to other areas. The QAPI committee can help triage that, what, when, and where changes can be tested next and then spread more widely. Learning some senior leader rounds, shift huddles, and other meetings in order to identify critical issues for improvement. Other reports include partnering activities and improvements with community organizations and other services and agencies, such as hospitals, home care, therapies, and transportation companies, on standardizing the transfer of resident COVID-19 information and status, plus protection practices. And certainly, findings from on-site CMS and state inspections are reported to and addressed by the QAPI committee. Since November, I have been serving on the National Nursing Home COVID-19 Action Network, a partnership between the Agency for Healthcare Research and Quality, the University of New Mexico's ECHO Institute, and the Institute for Healthcare Improvement. The network provides free training and mentorship to nursing homes across the U.S. to increase the implementation of evidence-based infection prevention and safety practices to protect residents and staff. Nursing homes completing a 16-week participation can receive a $6,000 stipend to assist with the cost of staff participation. The national network is authorized in the federal government by the Coronavirus Aid, Relief, and Economic Security, known as the CARES Act, COVID funding. To date, over 9,000 nursing homes have signed up, which means that almost half of all Americans living in nursing homes are likely to be impacted by this network so far. The content in the 16-week program includes all of the topics within the 6 goals, focusing on clinical practices for COVID, culture, and the psychological impact to all who live and work in nursing homes. Sessions also include quality improvement content, practical tips, and tools. As we work with these teams, we knew that we needed to adjust for their current context. They have less experience in improvement methodologies and fewer resources overall compared with hospitals. We met them where they are in terms of language and in terms of improvement. Since they are constantly testing for the virus, we talked about trying a change, not running tests of change. We didn't talk about testing with them, except about the virus. We used simple mapping to help them ask questions about where processes didn't work well, or people failed to perform the process as they were taught. We used their worst fears and biggest challenges to help them focus with us and to get them talking. Especially, an example is about the vaccine clinics. They were not part of the original curriculum plan, but they were now apparent. They were needing to work on that. And it quickly offered an opportunity for us to teach quality improvement methods and reliability thinking. As they shared their processes and attempts to try change, we used their stories to illustrate quality improvement techniques and taught QI terminology. We helped them clarify the structure and infrastructure for improvement, similar to Luther Park's infrastructure and how COVID-19 fits into the QAPI process. Nursing home staff are becoming expert noticers. They're noticing what's working and not working, and they're becoming experts in COVID-19 practices. In addition to the combination of COVID best practices and techniques for reliability and sustainability, we are also focusing on building the culture for change. Nursing homes are moving from only a large group trainings to more one-on-one and return demonstration or show back. Our nursing homes are moving from an auditing and compliance mentality to process improvement. For example, we help them see how the language for culture and improvement can be incorporated into designing new processes. Language barriers are quite a big problem for a number of our nursing homes. Also, rather than blaming people for not doing what is asked of them, they're learning how to discover what gets in the way when someone cannot do a process as taught. In order to improve the reliability of processes, it is useful to engage residents and families. They're excellent sources of information. We can ask residents' councils to share what they are worried about, what matters to them, and what they see around them in the facilities. What are their ideas for improvement? We find their ideas are often less complicated and easier to do than what we as leaders think about. Quite a few nursing homes are using angel rounds to check on residents, staff, and processes. More recently, with isolation and loneliness becoming such a big problem, these rounding teams are spending more time with each resident to understand their emotional well-being. An example from a team was working on why some residents were not wearing their masks. Well, they discovered that the availability of masks was a bigger issue than residents not wanting to wear a mask. The team developed a new standard process for mask storage, restocking, and local availability. Many new and redesigned activities have been developed to reduce loneliness, including video visits and fun in the hallways. Regular celebrations with favorite foods are happy hallway events. Pizza is popular. Drive-by and window visits from friends and families have been helpful. I understand that in Italy, family members attribute COVID deaths to a lack of prevention during the pandemic. We're not seeing very many examples of the families blaming nursing homes for deaths, but families are being kept up to date and know that their nursing homes are passing the rigorous inspections from CMS. As families are struggling most with wanting to be with their relatives in the nursing home, compassionate communications and keeping them informed, as well as video visits, are helping. As community positivity decreases, more in-person visits are being allowed now. I have heard that in Italy, there are many claims for compensation and complaints from family members for patients who died from COVID. I have not heard of many claims in my experience yet, but this may still happen, especially in more litigious states. Some of our states are passing legislation to protect nursing homes from liability from COVID, but this may not protect those who are not meeting the inspection expectations. Managing the well-beings of employees is also a crucial challenge. Keeping staff engaged with what's going well, what gets in their way is important, along with seeking and using their ideas for improvement. Making sure that all of the PPE and other supplies are easily available is helpful to settling them down. Nursing homes are providing professional services on site and by video with psychologists and grief and bereavement counselors. Debriefing at the end of shifts has been useful for us at Luther Park Community here in Des Moines. Staff tell us that they feel better at home when they debrief their struggles of the day before leaving the campus. Managers, leaders, and chaplains rotate participation in small group and individual debriefings. In managing staff challenge, it is critical that leaders be present, rounding frequently among staff to get to know them and understand their needs and fears, provides support, but it also enables caring attitudes. Protecting paid time is also crucial. Special offerings are now protecting staff wages when they are ill with COVID or on quarantine from being exposed. This is an important process for reducing and eliminating COVID spread across a nursing home when staff no longer come to work ill. At most critically short staffing times, administrators and business office staff step in to support care and services any way that's possible. Everyone helps. Some are now becoming certified patient care assistants or personal care assistants, and that's an 8-hour course with a test. The extreme impact of so much stress for so long will be a big challenge for all of healthcare in the months to come. Providing emotional support or psychological PPE is now a core topic in nursing homes. A few things that we have learned that can make a difference in the long haul include, besides managers showing that they care, career ladders are useful, especially when they include all of those in the lowest positions that they can see how they can progress all the way to nursing home administrator. People appreciate being valued and having opportunity for development. One leader is hiring these personal care assistants and then mentoring them to successfully become certified CNAs. Those hires from people who lost work in hospitality industries are an excellent fit. Some leaders are working with nurses to design different processes and pay schemes offered by hospitals. One thing that hospitals offer is a 4-10-hour day rather than 5 8-hour days. Nursing homes can also figure out how to do this if that's what their nurses want. Engaging them in making decisions, it makes a difference. We are hearing about nurses returning to their nursing homes after a few weeks of work in a hospital because their nursing homes offer a family culture where everyone helps each other and managers care about everyone. Across the U.S., commercial pharmacies are stepping in to provide and administer vaccines. In most states, a few of them use their National Guard. 3 successive clinics of 3 to 4 weeks apart are provided on site. Residents vaccinated in their rooms, staff vaccinated in large meeting rooms with nearby observation space following their vaccination. We have a remaining challenge, which is after the on-site clinics, how will others be vaccinated? In the US, about 80% of residents and 50% of staff are vaccinated so far. Staff are resisting for many reasons, mostly for fear of the vaccines. Some nursing homes are making a difference in getting the staff vaccinated with a process for helping employees research the facts around their fears and worries by helping clarify truths, partial truths, and misinformation. Some are calling this myth busting. Interviews with staff and small groups are useful to understanding the hesitation about COVID vaccines, but also for getting their ideas for encouraging their coworkers. We're finding that videos and messages from peers and experts are useful to relay the facts and decode the scientific messages. Some nursing homes are using incentives, small gifts, and bonuses, as well as paid time off. We thought that you would like to actually see some of the good news that we're finding as things begin to change. We call them paradigm shifts. So paradigm shifts, so things are changing a lot in the focus of the leader. So leaders were rounding in the past to surveil, to look for things that weren't right. But now their rounding includes support to the staff and the residents they serve. Change. When change was needed in the past, the first thing that happened was change the policies. But now they're working on redesigning the processes first. And once they're working, then writing policy and procedure. In the past, people did improvement. They're doing improvement, but now they're seeing themselves as improvers. Knowing what to do was what we focused on in the past. And now we know that we need to help people understand why the change is important. Why is it important to do this and to do it this way? One executive said to us, "When my staff know why, they are more apt to comply." Compliance of the past is turning to commitment to the best practices and doing it the right way. QAPI came down on us as a government thing, but QAPI now is the way we do it here. People used to say, we're doing our best, but now they're saying to each other, one lapse can lead to a death. People talked about their work as a job. Now people are talking more and more about their work as a family. Education was delivered always in groups, and now we know it must be more. That's necessary, but we need more. We need one-on-one reinforcement and education with return demonstration. Vaccine resistance is now turning into vaccine confidence. The emergency or disaster plan was on the shelf, seldom looked at, and was absolutely needed. But now the emergency plan and disaster plan is a living document, updated many times during this past year of many changes. CNAs, certified nursing assistants, were expected to stay in their lanes, but now they're perceived as critical to our care teams. We're also noticing the silver linings, things that couldn't have happened without this terrible pandemic. One is systemness, and I saw it very early on at Luther Park Community, where all of the managers, executives came together in a COVID response team. It included the finance director, it included the human resources director, and these people learned each other's struggles and failures. They learned how to help each other to get ideas, and they physically helped each other go move beds through the building into the isolation units. They worked together and made decisions so quickly and so effectively that we need to figure out how to keep. So there's systemness across the facility itself, but also externally into the communities and the states who supported our nursing homes in this terrible time. Employees are helping each other with reliable processes, reminders of where the mask needs to fit, and other things that they see, for instance, in cleaning and disinfecting. competitors, if nursing homes competing with each other in communities and regions are helping each other. This national network that I described to you, just think of 9,000 nursing homes across the nation with a target of 15,000, working together, learning together to be able to have more best practices in place reliably and to be able to sustain them in the long haul, even in the face of turnover in nursing home. So think about how nursing home delivery is going to be considerably different in our future. There are many technologies on the silver linings list, new and better technologies for air filtering, cleaning and disinfecting, and personal protection. Technologies used for communication, like connecting with loved ones, keeping families informed of policy changes. Nursing homes are using Zooms to collect their families together to hear the latest about what's going to happen. And when we open up again, this is how it's going to work, enabling them to ask their questions together. Also for advanced care planning, all of the family members that need to be participating, all of the clinicians who need to be participating can be on one Zoom session. The use of technologies to replace in-person visits, the infection control monitoring. We've had infection control practitioners on quarantine at home. Now they're watching with a video camera processes in place so that they can advise and make sure that things are safely being delivered. Also, the physical therapy check-ins for the residents. The attitudes are changing. People are saying we can. I was just on a session this morning where we heard a wonderful story about a whole week where there was terrible weather and the staff needed to live in the building to take care of the residents, and they all came together in an amazing way. They're saying to us, the teams are saying to us, we want to keep all the processes we improve, but the masks can go away. Things we took for granted, they're telling us, are now best practices. The feelings of progress, it's an exhilarating high. The actual length of the stride forward is not the point. That it is forward at all is a gift wrapped in a shiny paper of hope. Here are resources for you that may be useful. I wanted to point out on the second page that these blogs are stories from our nursing homes and what they told us, and they're posted on ihi.org. I look forward to your questions.